Hi, everyone. My name is Bram Rochwerg. I'm an ICU clinician and researcher based at McMaster University in Hamilton, Ontario, Canada. And it's my pleasure to provide this refresher on evidence-based fluid management in sepsis for the McMaster textbook. In terms of disclosures, I do work as a guideline methodologist for a number of critical care organizations. I'm an intensivist who regularly prescribes fluid for resuscitation in patients and do have funding for a publicly funded randomized controlled trial comparing crystalloids in the setting of septic shock. So we're really going to talk about different fluids that can be used in resuscitation in critically ill patients, specifically in the area of sepsis, as this is an area of interest of mine. However, a lot of the lessons learned are generalizable beyond sepsis. Fluids are a lot more complicated than they appear at the offset. I think for the uninitiated, we look at colloids versus crystalloids, perhaps with a lack of understanding that there are differences amongst the colloids when you consider things like starch, which are at the top of this table, not really used very much these days, given data that suggested that there was harm and risk in the early 2010s. Dextrans and gelatins, again, not really available. But primarily, when we start talking about different intravenous fluids, we're talking about albumins and crystalloids. Probably surprising to you is that there are actually different albumin products, as you can see in this table in the middle, and these different albumin products have different concentrations of electrolytes like sodium and chloride. Probably underappreciated and underconsidered when we're resuscitating a lot of our patients with albumin. Many of you probably don't even know which albumin is available within your units and which one you use. When it comes to crystalloids, saline, Ringer's lactate, probably the most commonly used crystalloids. And you can see that there are differences, subtle differences in osmolality, differences in sodium concentration, normal saline 154, lactated Ringer's 130, more closely resembling plasma, and differences in chloride concentration as well. And we'll get into this a little bit more as we go along. We'll start with colloids in the discussion and move to crystalloids next. I sort of alluded to this already, but when it comes to colloids, there are a number of options. Starches, although previously very popular, more recent data suggested harm and they're no longer used. Gelatins and dextrans, it depends on your jurisdiction that you practice in, but at least here in North America are not available for use. And so when we talk colloids beyond blood products, we're mostly talking about albumin. You're probably familiar with albumin, relatively familiar with albumin, at least as an endogenous molecule. It's synthesized in the liver, has a range of functions, and it is an acute phase reactant, which means that it is reduced in both acute and chronic illness. And we know that low levels of serum albumin are associated with worse outcomes. The question often presented to us is artificially resuscitating the albumin level, bringing up the albumin level associated with improved outcomes. And here we are less certain. Probably also important to mention is the cost associated with administering exogenous albumin. Compared to crystalloid, it is much, much more costly, approximately $130 US per 25 gram dose. There have been a number of randomized control trials that have looked at the utility of giving albumin for resuscitation in the ICU setting. And although these RCTs do show benefit in albumin in improving resuscitation endpoints, things like central venous pressure, MAP, cardiac index, none of the randomized controlled trials or meta-analysis have shown a benefit in patient-important outcomes. Here, the most recent meta-analysis looking at the impact of albumin versus crystalloid on the outcome of mortality. You can see a number of trials. The biggest one, the FIMFER trial, is the SAFE trial. Many are probably familiar with it, compared albumin versus crystalloid, and showed no difference. And when you look at the overall pooled point estimate, there is no difference in mortality when you compare resuscitation with albumin versus crystalloid. Confidence intervals that go from anywhere from about a 4% reduction in mortality to a 10% increase. And so despite the fact that there's no difference, we've already talked about the fact that albumin is more costly. And so in a choosing wisely era, no difference in mortality, despite improvements in resuscitation endpoints, why not use the most cheapest and widely available option, i.e. crystalloids? Beyond this, what a lot of folks will bring up is that fine, in a general critically ill population, there's no benefit in albumin, but what about selected subgroups, those with sepsis, TBI, etc.? And this table summarizes the most recent meta-analysis addressing a number of these conditions. You can see that in TBI patients, 5 randomized controlled trials, 1,500 patients, actually a signal toward worse outcomes with albumin compared to crystalloid. So actually a signal that albumin is associated with worse survival in patients with traumatic injury. Sepsis, 16 RCTs, perhaps a signal for benefit, but again, you can see confidence intervals that cross the line of no effect. So an element of uncertainty, and whether we think that this justifies the increased complexity and cost of albumin is for the prescriber, but I am personally not certain. Thermal injury, again, very wide confidence intervals, hard to make much in terms of a summary of effect in those with burn injury, and probably crystalloid a reasonable way to go. Similar in ARDS, small number of trials. I've only shown you here the outcome of mortality. You'll have to take my word for it that also there's no benefit, statistically significant benefit, clinically important benefit of albumin on other outcomes like need for renal replacement therapy or acute kidney injury in these subpopulations. Since looking more closely at this data, I'll tell you that my use of albumin has decreased substantially over the last couple of years. I used to use albumin much more frequently in the resuscitation setting, and I use it much less so. Again, with the understanding that it's probably not causing harm beyond the traumatic population, but definitely not sufficient data in my mind to justify the added costs that are present. The only population that I will still use albumin in, and I do believe that there's some data, I have the slides, but don't have capacity within this short lecture to go into it, it might be in the liver cirrhosis population. And so I do still, in the setting of SBP, in the setting of hepatorenal syndrome, in the setting of large volume paracentesis, I will still consider using albumin in those with liver cirrhosis. But when it comes to my practice, I've pretty much eliminated the use of albumin beyond the liver cirrhosis population, given the fact that we do not have a signal for benefit. Further research, definitely justified, but in my mind, it has not hit the threshold for diffuse use, again, given the costs. Let's move on from colloids to crystalloids, a source of lots of passionate debate in the last few years. This is an area of research interest to mine, and I'll tell you, when I embarked down this pathway, there was not a lot of enthusiasm around crystalloid, but it's become very popular, trendy to discuss in the last little while. We call normal saline normal, but I think many of you know that it is far from normal, having a sodium content 10% higher than that of extracellular fluid and a chloride content 50% higher. And we can debate and discuss the impact on clinical endpoints, but at least this higher chloride content has sequelae in vitro models, including hyperchloremic acidosis, decreased renal blood flow, an impact on gastric emptying, and smooth muscle contractility. We compare normal saline to balanced crystalloids. Balanced crystalloids, and the most common example here is Ringer's lactate. There's others like Ringer's acetate or plasmalite. They are able to achieve a chloride content that more closely resembles plasma, and they're able to do this by replacing chloride anions with organic anions like lactate and acetate. The question that we have faced in the last little while is, despite the potential physiologic benefits of using balanced crystalloid, does this translate into improvements in patient-important outcomes? And one of the largest trials we have to date that assessed this question, actually probably the largest, was the BASICS randomized control trial. It was actually a factorial design that also looked at rate of fluid administration. They compared plasmalite, which is, again, one of the more expensive balanced crystalloids, to normal saline in close to 11,000 patients across 75 ICUs in Brazil. Patients had to be admitted to ICU and had to have at least one of these factors that would suggest that they required ongoing fluid resuscitation. You can see that study patients received on average 2 to 3 liters of study fluid with very minimal open label fluid administration. The majority of the fluid was given on day 1 and decreasing returns as the days went up. You can see, again, fairly good protocol adherence. Despite this, no difference in the primary outcome of 90-day mortality when compared the saline versus balanced crystalloid solutions. These were surprising results when they came out a couple of years ago. Folks figured, the physiologic benefits of balanced crystalloid, the lower chloride content, this must translate into patient-important outcomes, and we did not see it across 11,000 critically ill patients. And there was no difference in 19 secondary outcomes, except for neurologic SOFA score at day 7, the only one that showed a potential harm with balanced crystalloid. And there is ongoing hypotheses that for those that have raised intracranial pressure, perhaps they require the slightly higher osmolality that's found in normal saline. So this is still the hypothesis that there's no difference between these fluids when you look at patient-important outcomes. Those with traumatic brain injury, high ICP may still benefit from normal saline. Following BASICS, the Australians published the PLUS trial, a second large randomized control trial addressing this question, similarly compared plasma light versus normal saline, and along with their RCT publication, they published an updated meta-analysis in this new journal, New England Journal Evidence. And comparing low risk of bias trials versus high risk of bias trials, you can see the overall pooled point estimate at the bottom here, and ultimately no difference between balanced crystalloid and saline when you pool all randomized control trials that have assessed this question, including BASICS and PLUS. The pooled point estimate suggests a 7% reduction in mortality with balanced crystalloid, but you can see wide confidence intervals that don't exclude benefit and harm. So hard to walk away from this and say, we should be using one type of crystalloid or the other. They did do subgroup analysis as part of this systematic review, and you can see, again, a signal for harm with balanced crystalloid in those with TBI, a pooled point estimate of 1.26, suggesting worse survival in those that received balanced crystalloid, and hard to walk away from any of these other subgroups and say, really, there's an important difference. When you look at sepsis, a point estimate suggesting maybe benefit to balanced crystalloid, but the upper end of the confidence interval crosses 1. So on a spectrum of normal saline is best, balanced crystalloid is best, I think we still believe that there are physiologic benefits perhaps to balanced crystalloid. These have not translated into an improvement in patient-important outcomes. And I think this has led us to this area of uncertainty and at least, justify those that want to continue to use saline. I think this is justified at this point, given the results of the most recent RCTs. Those that want to use balanced crystalloid justified, and ongoing indifference around whether one crystalloid might be better than the other. And this brings us, maybe just in the last couple of moments, to a little bit of summary of my own randomized control trial, the FISH trial, in which we are looking specifically at that sepsis subgroup. Again, if you remember from that subgroup analysis, if there's any folks that might benefit based on that subgroup analysis from balanced crystalloid, it might be those with sepsis. And so we're specifically looking at those with septic shock. Here, comparing saline versus Ringer's lactate instead of plasma light. The big randomized control trials use plasma light, the more expensive balanced crystalloid. We're looking at Ringer's lactate and seeing whether there's an impact on mortality. And some of the differences, despite 2 large randomized control trials, we're still persevering and moving ahead with this randomized control trial. Again, we're focusing only on septic shock as opposed to those other RCTs that looked at all critically ill patients. There's a high-risk cohort, and we're really trying to limit upfront fluid contamination, trying to maximize protocol adherence, showing that if there is an effect, this is the population and the group that we would see it. One of the exciting things is within the FISH trial is the volume of study fluid, because a lot of the previous fluid trials have included all critically ill patients. The amount of fluid resuscitation that these patients require is much lower. In FISH, we are only focusing on those with septic shock. This is translated into a large volume of study fluid. We've actually just crossed about 700 patients randomized with a goal of 1,100. So I'm hopeful that when I give this refresher in the next couple of years, we'll be able to fall back on the FISH study results and be able to provide you the most informed opinion around optimal crystalloid use for critically ill patients, probably generalizable to non-critically ill patients as well. And so I appreciate this opportunity to give you a quick refresher on fluids. To summarize, colloids, albumin is really the only one considered. Personally, based on the evidence that I presented, I have decreased my albumin usage as a resuscitation fluid in the ICU. Still worth further research, but outside of cirrhotic patients, I really don't use it very much. When it comes to crystalloid, we have our two options, saline, balanced crystalloid. Despite early physiologic data to suggest a benefit with balanced crystalloid, this has not translated into improvements in patient-important outcomes. Probably reasonable to use either fluid for now, but that FISH study, our FISH RCT, will hopefully give us more information in the coming years. I appreciate your time and attention. Thank you very much.